Hospital to Fellowship in Pediatric Critical Care Medicine. She's a member of the Society of Critical Care Medicine. She's an active member of multiple Rainbow committees, including Pediatric Critical Care Fellowship Clinical Competency Committee, Pediatric Education Portal Committee, Resident Wellness Committee, Graduate Clinical Education Committee, and Fellowship Education Committee. She's active in pediatric research within Rainbow, while being the principal investigator for UH's Research Health Analytics and Informatics Pilot Award that will be studying the characterization of the economic and social distress of children admitted to the Pediatric Intensive Care Unit using Pediatric Health Information Systems database. Please extend a warm welcome to Dr. Katherine Slane.
Hi, everybody. Thank you so much. I'm very excited to be here and talk to you a little bit about kind of my story and what I do, and hopefully inspire some of you. And thanks, Sarah, so much for that warm welcome. I really appreciate it. Please don't hesitate to interrupt me at any time if you have any questions. I'd like for this to be as casual as possible. And congratulations, you made it in the last talk. So. I'll tell you about my story, all right? So how did I get where I am? This is my brother, Charles. And Charles was born when I was 6 years old with incredibly complex congenital heart disease. And it really colored my entire childhood. And I think we all have an origin story. And so Charles is my origin, watching him experience his childhood with chronic disease and the impact his physicians and his multiple hospitalizations had on him and my parents, and as a sibling, inspired me to want to be a pediatrician. And that was that's how I so I decided to go into pediatrics because of Charles. And I remember the very first day that I walked into the pediatric intensive care unit as a medical student, and that was many years ago, and I still remember the energy and the excitement that I felt the first time I walked in, seeing a room like this. It ended up being an intensivist. So like this, it still gets really excited to take care of a patient right now that's in a room like this. But, you know, it surprised me as I went through my fellowship training and early part of my career as a faculty member. It wasn't the children like this that made me lose sleep at night. These weren't the ones that, so it was the kids that had the more common diagnoses, maybe even more benign diagnoses in the intensive care unit. It was the kids with asthma that were being admitted to the intensive care unit with critical asthma because they'd run out of medication and insurance wouldn't cover for the next meter dose inhaler. It was the kids that were admitted with DKA. The family's power was turned off and the insulin went bad because it requires refrigeration. It was the teachers that felt despair and didn't have support at home, that took too many tricyclics. Kids with seizures who came in to see their doctor to change their medications and came in with status epilepticus. Was this big beaten up at home and came in with traumatic brain injury. So these are ones because I wondered why they were in my intensive care unit in the first place. Why were your diagnoses preventable? And then even for the ones, the diagnoses that I thought maybe were preventable, you know, I'd walk in the ICU, and I still do, and I would notice that there were so many children that were alone, and they didn't have parents next to them. And it was because the parents couldn't pay for parking, couldn't afford to get a ride, or because their boss wouldn't let them out for work, or because kids at home and no one to babysit the kids. And so they're in my ICU right now that are there alone without parents because the situation prohibits the kids, the parents from being with the kids. And so these haunted me, and so I wondered if there was anything that we could be doing with these families, and I wondered if these children were coming in sicker. So were they sicker when they came into the ICU, and if they were sicker, why? I entered medicine because I wanted to help the world, and then I fell in love with the ICU and spent a long time focusing on individual patients and ventilator management and vasoactive titration. But then I've come full circle because I was frustrated at the ICU and how can I keep them out. So to take a little bit about what the American Academy of Pediatrics thinks about space and place and environment, and how does an environment affect a child's health. So this is called the Eco-Biodevelopmental Model of Health and Disease, created for this article in 2012 policy statement, the lifelong effects of early childhood adversity and toxic stress on a child's health. So if poor children are sicker, this model, this eco-biodevelopmental model of health and disease, offers at least, in part, so this model suggests that beginning prenatally and continuing on through infancy, childhood, and adolescence, and then into adulthood, development, a child, so their space, their home, their environment, interacts intimately and over a long term with their biology or their own biology. And both of these affect their development over the long term. So based on this model, could I come up with my own model, my own conceptual model of how a child's environment might affect the biology of critical illness when they come in sick to the hospital. The journey began, and I'll tell you a little bit about what I found and then what I'm hoping to continue to find. So this is where I started. So I started with bronchiolitis. I told you bronchiolitis is an incredibly common illness in the pediatric intensive care unit. And so could bronchiolitis be used as a kind of a first proving this model that ecology and home and space affects outcomes of bronchiolitis and critical illness. So although the incidence of bronchiolitis and hospital admissions has decreased in recent years, it still accounts for a significant portion of hospitalizations in children. So between years 2000 and 2009, this admissions accounted for an estimated 16% of all hospitalizations among children less than 16 years, less than 2 years of age. So incredibly common. It's incredibly expensive. So in 2009, as an example, bronchiolitis hospitalization cost $444 million in the United States. So it's expensive, and so therefore it's worthwhile to investigate and study. So there has been some evidence to show that there are some environmental risk factors for severity of illness and bronchiolitis. So boys, of course, as we are, so being a boy and infant male predisposes you for hospitalization. Being younger, crowding, so it's kind of a basic infectious disease principle. So bronchiolitis is passed by droplets and contact, and so if you share a room with your siblings in preschool and you're an infant, then you're more likely to get it, and then your exposure as well. There has some evidence, interestingly enough, that there's some social risk factors associated with severe bronchiolitis. So in a study, children with RSV, which is the predominant viral infection, hospitalization rates were higher for patients that had public insurance compared to those that had private insurance. Living in poor inner city neighborhoods had hospitalization rates for bronchiolitis compared to those children that were living in suburban areas. So based on this limited data that I decided to do my own study of the children with bronchiolitis that were admitted to our intensive care unit. So I looked at children that were admitted over a 1-year period, those pediatric intensive care. Grouped those children based on their estimated income level into poor households and not poor households. The way I did this is you can do this with any of your patients. You can look at their address. And their address, you can match it to the U.S. Census Bureau. And the U.S. Census Bureau will give you an estimate of what their household income is based on their address. So I took all of the addresses, the zip codes of all of my patients that were admitted with bronchiolitis, estimated what their household income was based on those zip codes, and then them into poor versus not poor, and then compared what their outcomes were based on what their estimated income was. So what was their length of stay, what was their need for mechanical ventilation, how long did they require any kind of respiratory support, including supplemental oxygen, and how much did their hospitalization cost based on their income level. So 145 children admitted during one respiratory season with bronchiolitis. Most of them were male because, you know, boys. And they were 5 months old. 3% of them had RSV. Half of African American and 40% were Caucasian. 31% were premature. And then, so these are down here. So FPT is federal poverty threshold. So 70% of the children admitted to the intensive care unit with bronchiolitis during this season had a median income that was 200% or less of the poverty threshold. What does that mean? So the federal poverty threshold for a family of 4 with two children is $24,000 a year. So if you make $24,000 a year and you have kids, then you are considered poor. So 70% of my children in this cohort were living on about $48,000 a year or less. 15% of them were considered poor, and 2 of the children, the families were living on less than $14,000 a year. So a low-income cohort, okay? All right, divided the children into poor versus not poor. So 63 children were living in poor household, so with an income of around $30,000 a year. And 82 children were living in a not poor household. And demographically, they were about the same except for their income. So there was no difference in what their age was or their race was. There was no difference in RSV infection. There was no difference in whether they or not they were premature. So other than the fact that one cohort was poor and one was not, so otherwise were relatively similar. Okay. How the children were poor had worse outcomes in the ICU. So they had a longer ICU length of stay. The kids that were poor were in ICU for 3 days compared to 2 days. They had higher or longer hospital length of stay. The poor kids were in the hospital for 6 days versus 4.5 days. They needed mechanical ventilation more frequently. 27% of the poor kids needed to be intubated, and only 13% of the not poor kids needed to be intubated. And it was more expensive, probably because they had longer hospital length of stay. It's more expensive for the poor kids. So it cost $45,000 for a hospital stay for the kids versus $28,000 for the not poor kids. I did the study all over again using a cohort. So the original study that I just showed you was in one hospital, respiratory season, 145 kids. But I wanted to see if there was any validity if I looked at a different population. So the Pediatric Health Information System is a database of around 40 to 45 children's hospitals nationally. It collects administrative data, including things like need surgery, all of the medications they've received, how long they stay in the hospital, what kind of, if they see you or not. So a lot of what all of their discharge diagnoses, admission diagnoses, comorbidities, et cetera, et cetera. So this database, I'll say this next study. So it's less than 2 primary diagnosis of bronchiolitis. I classified them as poor versus not poor, again, based on their home zip code. The variants are a little bit different. Like, I couldn't look at all of the granular stuff that I could look at with our EMR, but we looked at length of stay, the need for mechanical ventilation, and how expensive was the hospitalization. So, paragraph on the left are the poor kids, on the right are the not poor kids. There were over 6,000 kids in this study. Being poor were more at risk for needing mechanical ventilation. Being poor meant that you had a longer hospital length of stay, 6 days versus 5 days. Being your hospitalization was more expensive, $47,000 versus $43,000. And so the cost of hospitalization for bronchiolitis stay was more than yearly income for these families. So I was 6 when Charles was born. He had all of his surgeries, but between the ages when I was 6 and about 15 or so, every time he went into the hospital, it was like a bomb went off in my mom would move into the hospital. She'd be there for a month. My grandmother would move in. I had to stop taking ballet lessons. My dad was self-employed, and so he was working part-time. My mom was employed. Thankfully, her job allowed her to stop working. But, you know, it was like someone had taken us over and was shaking us upside down. And so if it was like that for our family, who had no financial instability, who had parents that live across the street and could come in and move in, what in the world must a serious hospitalization be like for a family that doesn't have the same financial and social structure that my family did? And so the next eco-biodevelopmental framework, and so I have some evidence that problem, right? I need to start thinking about that problem for all of my patients. I need to come up with my own framework. The American Academy of Pediatrics created this for children in general, and their focus is on development, right? What I need to understand, or what I need to understand, is how does the social and physical environment affect PICU outcomes? I'll walk you through this. I'm getting behind. So how does the child's home environment protect against illness or children, risk behaviors that might predispose a child to coming to the intensive care, and thus decreased wellness overall? Assume that a child's space and place might cause high illness burden, more risky behaviors, the need to some sort of physiologic disruption in the child and decreased health results. And this would naturally lead to higher illness severity. So the I'm working with, I start identifying these factors in kind of a methodical, quantitative way to identify what's causing higher, or are they actually children that are coming from impoverished households or fragile households at higher risk for ICU admission, and are they sicker at hospital presentation? So how am I going to define space? The way I have decided to look at a child's space includes their adverse childhood experiences, and I'll talk about this in a few minutes, and of the family stress, family resilience or lack of it. How do these three things intertwine to affect the home life? And if these things do intertwine and affect the home life, then what effects do they have on kids that are admitted to the hospital critically ill? But these kind of three-legged stool, okay? So childhood experiences, let's talk about that first. So the Adverse Childhood Experience Study, landmark study published in the late 1990s. So what this group did, what Dr. Folletti did, was he surveyed 13,000 adults in Kaiser Permanente health system in San Diego. So the adults, they were coming in for their annual physical exam. And after the annual physical exam, where they collected information about their general health state, so what are all of their comorbidities, what are their current medications they're on, did all of that information, and then surveys were mailed to these 13,000 adults. And the surveys, the questionnaire, were including questions about different types of what are now termed adverse childhood events, including abuse and exposure to other forms of childhood dysfunction while they were growing up. Questionnaires were distributed to the 13,000 adults. 9,500 completed the questionnaire. And medical charts of those 9,500 patients were reviewed. Presence of risk factors that are associated with unfavorable health outcomes in adults. So things like smoking and obesity and alcoholism and drug use, those kind of risk factors and unhealthy behaviors. And then patients were followed longitudinally to see if they had unfavorable health outcomes. So, yeah, for example, heart failure, heart disease, diabetes, etc. Health outcomes were tracked. So the questions that were asked on the questionnaire and how many the adults reported these things had happened in their childhood. So 20% of the adults reported that they had experienced sexual abuse as children. A quarter of the adults reported they had been exposed to a family member in the house that were an alcoholic, 5 exposed to drug abuse. 80% were exposed to mental illness in the home, with 4% of caregivers committing suicide or attempting suicide. So it's highly prevalent, these adverse childhood events or exposures. In the 100 adults who completed a survey, more than half of the respondents experienced at least one form of adverse childhood event during childhood, and a full 6% experienced 4 more. They looked to see if presence of an adverse childhood experience was associated at all with risky behaviors and favorable health outcomes, and they did. So it was a dose-dependent response. So the more adverse childhood experiences you were exposed to, the more likely you were to smoke as an adult, the more likely you were to use IV drugs, the more likely you were to have an STD, to have alcoholism or drug abuse or suicidality. And this was across the board, and it was statistically significant for all of the risk factors. Okay, dose-dependent response. So across the board, the more adversity that you were exposed to in childhood, the more likely as an adult you were to have heart disease, cancer, stroke, emphysema, diabetes, fractures, hepatitis, and self-reported poor health outcomes. So wait a minute, like this is a big deal, right? The things that are happening in our children just as an important public health burden, smoking and drinking much, drug use, where a child comes from and their home environment puts just as much risk on outcomes as adults as all those other things. So we are all pediatrics. We have to start thinking about that right now, right? Even an intensivist, this stuff is important. So it's important to think about what their risk factors are for adulthood, but as an intensivist, I also wanted to figure out, and we should be thinking about, how does it affect their outcomes currently, right? So how are these children that are exposed to these things as toddlers and young children, how is it affecting their health right now? Some literature on this as well, and this part is really growing, so it's not as much. So how do ACEs, adverse childhood experiences or events, affect childhood disease, not just adult disease? So in this study, investigators recruited children 4 years or younger who had either been abused or were at high risk for treatment. So it's a biased sample. So they had already been identified as being at risk. And 2-hour interviews were conducted with over 1,000 caregivers, so mainly mothers or foster mothers. And then investigators looked to see if there was an association between childhood adversity and then that caregiver's self-report of poor health in the child. And so, since I just told you this with adults, but like the previous study, there was a dose-dependent response or dose-dependent association between ACEs and parents reporting poor health in the child. And also, because this is it's qualitative and it's just kind of a subjective feeling, is your child in poor health? But then they also tried to quantify it in some way by saying, has your child been sick enough to require medical attention? So again, a dose-dependent response. The more adversity that the child experienced, more likely they were to seek medical care or need to seek medical care. So drug use. Not surprisingly, young children exposed to an unhealthy environment, young children, are more likely to use drugs as teenagers. So this is from 2003. This is actually a secondary analysis of the original adverse childhood exposure study, the survey study. This data is based on the interviews of those adults, those 9,500 adults, self-reporting on their exposure to adversity and then their subsequent drug use as teenagers. And what we found was the more adversity that they were exposed to as young children, the more likely they were to use drugs as teenagers. This O and her colleagues is a very nice systematic review of what is currently known about adverse childhood experiences and how it relates to peak health outcomes. So if you're exposed to things as a young child, how does that affect your health sometime during childhood? Of note, one of the authors of this study, Dr. Burke Harris, she will be speaking. She's actually a pretty well-known speaker on adverse childhood exposure, and she is going to be speaking actually in this auditorium. I wrote it down. March 1st at 8 o'clock in the morning, and it's open to the public, and she talks about kind of her journey as well, becoming an investigator in adverse childhood experiences in outpatient clinic. She is a general pediatrician. TED Talk. So anyway, so this study, if you want to get a summary statement of what is currently known, says that childhood adversity is associated with height. Interesting, right? So the more adverse, more adversity, the shorter you are. Cognitive ability, cortisol levels, cortisol is a stress hormone, obesity, asthma, infections, somatic complaints, and poor sleep. All right. So, how do you figure out your own patient population and children that you see on a daily basis? What are they supposed to do? And included on here should have the American Academy of Pediatrics. If you type in AAP and ACEs, they give some nice questionnaires that you can use in your own practice as part of your social history. And then you can also look at a more population level, the ACEs exposure in your community. Unfortunately, Cleveland, we have a pretty fragile society. So the national data is all the way over on the right. So nationally, about half of all children are exposed to about one adverse event in their childhood, whereas in Cleveland it's 65%. I thought really interesting that almost 8% of children in Cleveland have experienced the death of a parent. So these three websites that I listed here are population-based data that's open to the public so that you actually start to understand your own community in your neighborhood. So you can actually, as an example, you could put in the address of where your clinic is and start to kind of create your own map in your head of what the children in your clinic's neighborhood look like, including of the neighborhoods surrounding your community, the poverty rate, what kind of families have, what percentage of families in your neighborhood receive benefits or supplemental income from the federal government. These websites are a great wealth of knowledge, and they can even help you kind of very easily, they're very user-friendly, create kind of concept maps to see like what actually your neighborhood looks like visually. So even if you choose not to enter families directly, and specifically that's much of a leap right now, because you know a lot of us, if we're going to ask a family if they're having problems with abuse at home, well, we should all be asking that. You need to have a safety plan, right? So you want to make sure that the questions that you're asking, that there's a follow-up plan, that you have a social worker that you can refer them to, that there are community resources that you can refer them to. And if you're not ready to take that step when you're interacting with your family, is at least starting to understand what the social environment of the neighborhood around you. These websites are helpful for that. Our first childhood events or experiences. So the second leg of the three-legged stool that I'm creating for myself when I'm trying to understand critically ill children and how this stuff is affecting them is poverty. And I talked to you about the research I've already done thus far, but let's talk a little bit about the other research, poverty and child health. So poverty is a problem in Cleveland. This map, so dark blue is bad. So areas in dark blue, so these are all zip codes. These are zip codes where, in dark blue, over 40% of the children in these zip codes are living below the federal poverty level. Again, that means they're living in a household annual income of less than $24,000 a year. A problem here in Cleveland. We know that poverty is associated. We've been well established that poverty is associated with infant mortality, adolescent pregnancy, low birth weight, delayed growth and development, hypertension, asthma, substance abuse, poor health, of course, mental health, and poor school performance. The Academy of Pediatrics released a policy statement, a call to action for all pediatric providers, saying child poverty is unacceptable and detrimental to the health and well-being of children. The AAP committed to its elimination, and all pediatric providers should be committed to its elimination as well. the research currently that's available, that poverty is also associated with unfavorable outcomes in hospitalized children. So it's not just an outpatient problem with poor performance and mental health. It's also an inpatient problem. So these next two studies use the FIS database. That was that big database of 45 children's hospitals that I used. The second one, I used bronchiolitis study. This first one, Enders did a cost analysis of 10 indications for hospitalization, doing things like asthma, DKA, pneumonia, and looked to see if poor kids, if their cost of hospitalization was higher, if they were poor. They did find that poor kids, that their hospitalizations were more expensive. So they took the kids, bucketed them into different income levels. On the left-hand side, those are the poorest kids living in households where the income is less than $33,000 a year. And the right-hand side, it's greater than $67,000 a year. So this is cost. So this is, should it cost the hospital to have these children admitted? So across the board, except for urinary tract infection, so across the board, the poorer, the more expensive the hospitalization was for the hospital. And then kind of second set below where it says patient, across the board, the more expensive the hospitalization was for the actual patient. So the costs accrued by the family. And all of these things, asthma, diabetes, bronchiolitis, pneumonia, one that there was not a difference was in kids who were with urinary tract infection. Fragile children, our most fragile families, are bearing the greatest burden of these illnesses. Again, used this database, and the investigators looked at differences based, again, on home income level and outcomes in children undergoing heart surgery. And what they get children from families, not for costs, but also had longer lengths of stay and higher mortality. And these are admitted to the hospital being a cardiac surgery. So the last of the three-legged stool is family. This one for me is much harder to quantify. So how does family stress and coping or inability to cope play into this home environment? Because sex can be protective, right? Just being poor does not mean that you're fragile if you have a support network, right? So a family that has a strong community, a strong church, a strong network, be able to deal with the stress of a major hospitalization, the stress of the illness of a child, kind of quantify that is important too. So this was done by a group in Cincinnati Children's. So investigators did was they conducted focus groups, individual interviews of 60 parents of children that recently been hospitalized. And these were just kind of general wards hospitalizations, and these were not PICU patients. And they identified common themes, interviews, and these themes included issues with logistics related to the hospitalization, so things like to and from the hospital, childcare for the other children who's taking care of the kids while one child is hospitalized, emotional themes, so just the general frustration, stress, fear, anxiety, worry related to hospitalization, and financial themes. It's expensive. Your child's admitted to the hospital. You have to buy food. You have to pay for parking. You lose income, lost work hours. And identify these themes and then try to figure out if there were differences between the way poor families versus not poor families managed the stress of these acute hospitalizations. And not surprisingly, they found a difference. So again, families that came from lower socioeconomic status across the board experienced challenges in all three of these areas: logistical, emotional, and financial. These core families are pretty powerful and help remind us the things that they're dealing with. Hours to get to a pharmacy. 2 hours are walking, and 2 hours to get back. A family from the hospital of their medications in hand before they leave. They do all the time. So they walk down to the pharmacy inside your hospital and pick up their medication before they leave. I think the doctors realize the financial toll that the parents take. It's just, okay, we're going to send you home. You can always come back if there's a problem. Well, they're $150 deductible for me to go to the emergency room. $24,000 a year. $80. I'm in the hospital with no money, with no one, no food, no gas. It was horrible because I was breastfeeding and I'm basically eating nothing but cereal or a little scrap that my child don't eat that I could sneak in before the doctors come and see. The PICU meals families unless the mom is breastfeeding, hungry, others in the intensive care unit. The legs of the stool that I am creating, we in the intensive care unit need to look at and consider for every single patient that comes into our ICU. Need to be screened at admission, and we are in the process of starting a study to do this. We need to demographics of our patients. So over a year, 100 patients, and half of the children that come into the intensive care unit are considered low income by federal guidelines, so meaning that they're living with an income of less than $48,000 a year. So we have to describe that and be robust about it. Social history, so that we can understand all of the stressors that these families are facing, and then we need to figure out how we're going to help them. Because for these, a bomb did go off in their lives as a community institution responsible for helping them. So here's in sicker likely are going to have unfavorable hospital outcomes, including longer lengths of stay, more frequent interventions, such as needing mechanical ventilation. They likely are going to be at increased risk for remission, not as they're coming in sicker, but also because their families are probably going to have challenges reading them at home, right? So that's going to make it a challenge, make them more at risk for coming back to the hospital. And they're probably going to be more at risk for suffering what is now termed post-intensive care syndrome. So this is kind of the next frontier in critical illness. So after major hospitalization, we know that adults and children are more at risk for having neurologic morbidity, so loss of milestones, for example. And so these children are probably much more at risk for suffering from this post-intensive care syndrome than children that come from more affluent families. So this is a model I have in my head. This is the journey that I have started on. And I hope that perhaps it will inspire some of you to take a fresh look at your own patient population, to start to consider the environment and how that might be affecting the health of your particular patient population. And if there's some small steps that you can start taking in your own clinic to see if you can mitigate some of those factors. So things that you can think about are screening for ACEs. So again, go to the American Academy of Pediatrics. They give you some great screening tools. making sure that your social history is going to be helpful for your patients. Understand the neighborhood demographics of your patient, where your patients come from, and what do those neighborhoods look like. Create your own concept map. So this is what I have done for critically ill patients, but if you're working in a neurology clinic and you deal with chronic headaches, or you're working in a GI clinic and dealing with chronic abdominal pain, the things that might affect these families might be different. And what are some small things that you can do to make your patients' lives easier? So is there a pharmacy that you can send them to that's next door to your clinic, or send them to the pharmacy before you discharge them? Can you stamp forms, including communication with company and keeping lights on? Are there any resources that you can partner with so you can make sure that these families are connected? Can you change office hours so that moms that can't work, not allowed, and so can you early or stay late? Interface with the school. These are captive audience, so can you capture these children at school and communicate with the school nurse? For a thought, thank you, and any questions? Yeah. Yeah. Yep. Mhm. Yeah. The question is what do we do when we don't have any resources? So you are exactly. Right now we do not have a leg to stand on, and so why it's a systemic problem and it needs to be a systemic change. And so step one is recognizing that there's a problem and talking about it, right? And step number two is going to be approaching the things that we can approach as medical providers. So the medicine stuff has to be tight, right? We have to make sure that their insurance is up to date. We have to make sure that they have all of their medicines. We have to make sure that their asthma action plan is written in a level that the families can understand. And we have to start communicating and interfacing with the people who are involved in these child's life, not hospital. So we have to engage the pediatrician, we have the social worker, engage the family, right? There needs to be a conversation with mom about cleanliness and exposure and smoke exposure and all of those things. There needs to be a communication with the pathologist. There needs to be communication with the teachers. So they're your biggest advocate for the child outside of the home are going to be these. And so that's all we've got right now, which is unfortunate, which is why people like to figure out how to change it. Because my envision is that we take a patient population like asthmatics, and find that there's a systemic problem with the home environment for these children that keep coming back, right, multiple readmissions, and then we partner with community services to go to the homes and help them. So how is it that we get the Cleveland Department of Health involved in these families? How is it we get the housing department involved in these families to start changing the rules? Landlords are required to keep homes clean. How is it that we get charity partners so that we make sure that families have clean nurses and cleaning supplies and vacuum cleaners. So I think it needs to start here with all of us talking about it, and then we need to start reaching out into the community, and our community partners are going to be the ones that really help with the home environment. Yeah. Yeah. It was that this is a stigma. 100%. Yes. Yes. So that's we are judgmental of parents that are not at the bedside. The reason they are not at the bedside is because they can't be. They're safe in the hospital. Their other children at home are not. So yes, yellow.
Problem like for you is great, and then it's yeah, I agree. Yes, when are we going to get?
Yes.
And so that's where you are.
Yes.
And I guess it is.
Yes.
When I hear this, I know.
Mm-hmm.
And I feel like you have instead of that mom or back and I'll say, you know, we blame them for not, you know,
Yes.
and so I think, and so I feel like a lot of
What's your role?
I'm a pediatric sleep nurse, so I go in after the doctor and
translate all the stuff. Yeah.
like a lot of times they can't even ever come to the doctor. And I'm like, all right,
Yeah.
so I keep saying it. They need to ask or so they're not as but the education and words, ways that you understand how to
You start talking about it, right? So that's what we're doing in the intensive care unit. Like, hey guys, this is a problem. Start talking about it and figure out what we as an intensive care unit to help these children for the 2 days they're in our care. What can we do for the next 2 days to make this mom's life a little bit easier and to make her transition to home a little bit easier? And for every one of you, where you work, it's going to be different. But number one is to have a conversation about it and start on what you think the struggles are that these families are having, whether it's just a simple understanding or any problem or a resource problem. So that's every group is going to be different. Yep, back again. Uh-huh. Yep. Yeah. I had study, but it's a great question. Right? Intuitively, you would think that a parent. Yeah. Yes, absolutely. And yes. Mm-hmm. Yep. 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 So what so I just applied for a grant, so everybody keep their fingers crossed that I get it. So the grant that I just applied for is to do interviews with 100 families that are admitted to the intensive care unit, asking all of these questions. What is your income level? Do you have a car? Do you have a phone? Do you have someone taking care of your other children? Is your child exposed to violence? And all of these questions. Tell me about the experience of this hospitalization. What have the challenges been? Are you having problems with food? Did you lose your job? So 100 families, all these questions. And then I'm going to have 100 patients worth of data. And then I'm going to go find someone to talk to. I don't know who that's going to be yet. But say, like, look, we are failing, right? We're failing. And so then, yes, that will be it. So first I got to show that there's a problem, because people more than me need to, like, see data. They're not going to just, like, I'm, preaching like this. And then say, this is a problem. I've quantified it for you. This is how much it would cost to fix it for the 3 days that they're with us. Show that to our families. And can change patient on family-centered rounds by providing the family with parking passes and Uber rides. Well, see, PICU doesn't do breastfeeding. It's only for kids that are discharged from the hospital, not discharged from the PICU. Yes, it would. So, thank you. Thank you, I really appreciate it. We went for a flower and then they had questions.
Just a few closing remarks. We just wanted to thank all of our wonderful speakers. Thank you very much, Dr. Slane.
It's in your pocket. Okay.
Thank you so much. Evaluations, if you could please make sure you fill those out. Those are in the folders we gave you initially. There's blue boxes on the table right outside where you initially registered. If you could please place those there. And then, as mentioned in the beginning, please make sure you fill out your reviews so you do get credit for when you upload those to your certifying board. Thank you, tutors. Hope you guys got a chance to speak to them. If you have any follow-up questions, please don't hesitate to email myself, Sarah Bania, or Brandy Childress. We'll be happy to address any concerns you have or give you further information. Thank you all much for attending. If you are a non-UH employee and or an off-campus UH employee that does not have parking privileges here, you can see one of the girls outside, and we'll give you, as long as you have your parking ticket, we can give you a validated parking pass and just hand both of those to the person when you're leaving. Any questions or anything that I can address? Thank you for coming.